Hello everyone and welcome back to Neethu Nursing Insight. In today's video, we are going to learn about one of the most important neurological assessment tools used in nursing practice, that is Glasgow Coma Scale or GCS. By the end of this video, you will understand what the Glasgow Coma Scale is, why we assess GCS, how to assess each of its three components, how to calculate the total GCS score, how to document GCS correctly, and some important points nurses should remember during neurological assessment. So let's get started. What is the Glasgow Coma Scale? The Glasgow Coma Scale, commonly known as the GCS, is a standardized neurological assessment tool used to assess a patient's level of consciousness and responsiveness. The GCS evaluates three components: eye opening, verbal response, and motor response. We usually remember these as E, V, and M. The total GCS score ranges from 3 to 15. 15 is the highest possible score and 3 is the lowest possible score. However, one very important point to remember is that GCS should never be interpreted in isolation. As nurses, we should also consider the patient's baseline condition, clinical presentation, medications, sedation, airway status, and other neurological findings. Why is GCS important for nurses? GCS is important because changes in a patient's level of consciousness can be an early indication of neurological or clinical deterioration. We commonly use GCS when caring for patients with conditions such as head injury, stroke, altered level of consciousness, seizures, neurological disorders, critical illness, suspected intracranial problems, and patients requiring frequent neurological observations. But remember, the most important thing is not simply recording one GCS score. We need to compare the current assessment with the patient's previous assessment. For example, if a patient's GCS was 15 earlier and later decreased to 13, that change is clinically significant and requires reassessment and appropriate escalation according to the clinical situation or local policy. So, always remember, the trend is very important. Components of the Glasgow Coma Scale. Now let's understand the three components of the GCS one by one. First, eye opening or E. Eye opening is scored from 1 to 4. E4, spontaneous. If the patient eyes are already open without any stimulation, the score is E4, spontaneous eye opening. For example, the patient is awake, looking around the room and interacting with the environment. That is E4. E3, to voice. If the patient does not open their eyes spontaneously but opens them when you speak to them, the score is E3 or eye opening to voice. For example, you say, "Mr. Ahmad, can you open your eyes?" And the patient opens their eyes in response to your voice. That is E3. E2, to pressure. If the patient does not open their eyes spontaneously or in response to voice, but opens their eyes following an appropriate physical stimulus, the score is E2. The exact method of stimulation should always follow your hospital policy, clinical guidance, and appropriate training. E1, none. If there is no eye opening, even with appropriate stimulation, the score is E1. No eye opening. So for eye opening, remember 4 spontaneous, 3 to voice, 2 to pressure, 1 none. Second one is verbal response or V. The second component is the verbal response, which is scored them 1 to 5. V5, oriented. If the patient is able to communicate appropriately and demonstrates orientation, the score is V5, oriented. For example, you may ask, "Can you tell me your name? Where are you? What month or year it is?" If the patient responds appropriately and demonstrates orientation, the score is V5. V4, confused. The patient is able to speak and communicate, but their responses demonstrate confusion or disorientation. For example, the patient may be talking normally but is unable to correctly identify where they are or what is happening. That is V4, confused. V3. Inappropriate words. The patient produces recognizable words, but the words are inappropriate or unrelated to the questions being asked. That is V3. Inappropriate words. V2. Incomprehensible sounds. The patient makes sounds such as moaning or groaning, but there are no recognizable words. That is V2. Incomprehensible sounds. V1. None. If there is no verbal response, the score is V1. No verbal response. So remember, 5 oriented, 4 confused, 3 inappropriate words, 2 incomprehensible sounds, 1 none. Important points intubated patients. Now there is an important point for nurses when assessing an intubated patient. If the patient is intubated, they cannot produce a normal verbal response because of the endotracheal tube. We should not simply assume that the verbal score is 1. Instead of that, the limitations should be documented according to your hospital's or local GCS documentation policy. Depending on the documentation system being used, the verbal component may be recorded as not testable because of intubation or using another approved notation. So, always follow your institutional policy and documentational guidelines. The third component is the motor response, which is scored them 1 to 6. M6. Obeys commands. This is the highest motor score. If the patient follows a simple command appropriately, the score is M6. Obeys commands. For example, lift your right arm, show me 2 fingers, move your toes. If the patient follows the command appropriately, the score is M6. M5. Localizes. If the patient does not simply follow a command but makes a purposeful movement towards the source of stimulation, this is called localizing. The score is M5. Localizes. This is different from simply withdrawing the limb. M4. Withdraws. If the patient pulls the limb away from the stimulus but does not purposefully attempt to locate the stimulus, the score is M4. Withdraws. M3. Abnormal flexion. If the patient demonstrates an abnormal flexion response, the score is M3 or abnormal flexion. M2. Abnormal extension. If the patient demonstrates an abnormal extension response, the score is M2 or abnormal extension. M1. If there is no motor response, the score is M1. No motor response. So, motor response is 6 obeys commands, 5 localizes, 4 withdraws, 3 abnormal flexion, 2 abnormal extension, 1 none. How to calculate the GCS score? Now let's see how to calculate the total GCS score. The formula is very simple. I plus verbal plus motor equals total GCS. For example, suppose the patient opens their eyes spontaneously, E4, is confused when answering questions, V4, obeys commands, M6. So, E4 plus V4 plus M6 equals GCS 14/15. Here is another example. Suppose the patient opens their eyes to voice E3, uses inappropriate words V3, withdraws from stimulation M4. So, E3 plus V3 plus M4 equals GCS 10/15. But there is one important documentation point here. Instead of documenting only GCS 10, it is much more informative to document GCS 10/15, E3, V3, M4. This tells the healthcare team exactly how the patient responded in each component. GCS 15 does not mean the entire neurological assessment is normal. Another important point for nurses is that a GCS of 15/15 does not necessarily mean that the patient's entire neurological assessment is normal. For example, a patient may have a GCS of 15 but still have facial asymmetry, weakness on one side, speech difficulties, visual changes, abnormal pupil findings, loss of sensation, poor coordination. Therefore, GCS should be considered one part of the neurological assessment, not the entire neurological assessment. What should the nurse assess along with the GCS? Depending on the patient's condition and clinical setting, neurological assessment may also include level of consciousness and orientation, pupil size, equality and reaction to light, speech and communication, motor strength and movement, sensation, facial symmetry, coordination and gait when appropriate, seizure activity, headache and other neurological symptoms, vital signs and oxygenation, and most importantly, any change from the patient's previous neurological status. Always look at the whole clinical picture. Factors that can affect the GCS assessment. As nurses, we also need to consider factors that may interfere with an accurate GCS assessment. These may include sedative medications, analgesics, intoxication, intubation, language barriers, hearing impairment, facial or oral injuries, severe speech impairment, and other conditions that may prevent the patient from responding normally. Therefore, always consider the clinical context before interfering the GCS score. What should the nurse do if the GCS decreases? Now let's discuss an important question. What should a nurse do if the patient's GCS decreases? Suppose the patient's GCS was 15 earlier and now it has decreased. As nurses, we should not simply record the new number and move on. First, reassess the patient and confirm the findings. Make sure the assessment is accurate. Then, assess the patient's airway, breathing and circulation. Check the patient's oxygenation and vital signs and repeat the neurological assessment including the individual E, V and M components. Look for any other neurological changes such as changes in pupil response, motor strength, speech, facial symmetry or level of consciousness. Also review the patient's medications and recent interventions because medications such as sedatives or analgesics may affect the level of consciousness. Finally, escalate the change according to your hospital policy, clinical protocol and patient's condition. A new or unexplained reduction in consciousness is clinically significant and should always be taken seriously. Remember, do not just document the decrease. Reassess, identify possible causes, monitor the patient closely and escalate appropriately. Common nursing mistakes when assessing GCS. There are several common mistakes that nurses should avoid when assessing Glasgow Coma Scale. First, do not guess the score. Always assess the patient's actual response and assign the appropriate score based on what you observed. Second, do not automatically assign a verbal score of 1 to an intubated patient. An intubated patient cannot provide a normal verbal response because of the endotracheal tube. The verbal component should be documented according to your hospital's GCS documentation system and local policy, taking the clinical context into consideration. Third, do not focus only on the total score. Always look at the individual components. E, eye opening, V, verbal response, M, motor response. For example, documenting GCS 10 by 15, E3, V3, M4 provides much more information than simply writing GCS 10. For example, documenting GCS 10 by 15, E3, V3, M4 provides much more information than simply writing GCS 10. Fourth, do not compare the patient only with the textbook normal score. A GCS of 15 may be considered the highest score, but what is most important clinically is often the change from the patient's own previous neurological status. Whenever possible, compare the current assessment with previous assessments. Fifth, do not ignore small changes. Even a small change in neurological status may be clinically important, especially if it is new, unexplained or associated with other changes in the patient's condition. So, always assess the patient, the individual components and the trend over time. Quick revision. How to remember GCS? For a quick revision, you can remember GCS using E, V and M. E, eye opening 4 to 1. V, verbal response 5 to 1. M, motor response 6 to 1. So, maximum score 4 plus 5 plus 6 is equal to 15. And minimum score 1 plus 1 plus 1 is equal to 3. The formula is GCS is equal to E plus V plus M. This simple method can help you quickly remember the scoring system during your nursing studies and clinical practice. Final nursing message. So let's summarize what we have learned today. The Glasgow Coma Scale is a standardized tool used to assess 3 important components of a patient's level of consciousness: eye opening, verbal response and motor response. It provides nurses and other healthcare professionals with a structured way to assess and communicate a patient's responsiveness. However, remember that GCS is not a substitute for a complete neurological assessment. As nurses, our responsibility is to recognize the patient's baseline neurological status, perform the GCS assessment accurately, assess and document the individual E, V and M components, identify changes as early as possible, reassess when there is a changes or concern, consider the overall clinical condition, document clearly and escalate significant deterioration promptly. Most importantly, remember this: don't just look at the number, look at the patient, look at the trend and look for changes. Thank you so much for watching Neethu Nursing Insight. I hope this video has helped you understand the Glasgow Coma Scale more clearly and given you a better understanding of how to assess and document GCS confidently in nursing practice. If you found this video helpful, please give it a thumbs up, share it with your friends and classmates and subscribe to Neethu Nursing Insight for more nursing related videos. And don't forget to press the notification bell so you will be notified whenever I upload a new video. If you have any questions or suggestions about this topic, please leave them in the comment section below. I will be happy to answer you. Thank you once again for watching. I will see you in the next video with another important nursing topic. Until then, stay safe, keep learning and keep caring. Thank you and take care.